So let's see. So when people say Castleman disease, we really think about Castleman's as describing a group of disorders that all look the same under the microscope. So in all of our cases, if you cut out our lymph node and look under the microscope, the lymph node looks the same under the microscope, but the symptoms we have vary quite substantially. So there's unicentric Castleman disease, which is probably the most common of the various subtypes of Castleman disease. It's the type where, as you've heard from some folks in the room, that when you cut it out, you're supposed to be cured and it's not supposed to come back. Your symptoms are supposed to go away, but that's not always the case. That was something that really emerged from these patient summits over the years, where patients are saying, no, I got it cut out and I haven't gone back to feeling like myself. I actually feel lousy still. I feel horrible. And so that's become very clear. In terms of survival, so patients really struggle. It can be really challenging. In terms of survival rates are good generally. There's some low risk but serious sequelae or things that can happen following a unicentric Castleman's diagnosis, including something called perineoplastic pemphigus, where you get some skin changes that are concerning, and we can talk through what that could look like. And you also have to make sure that you're aware of a slightly increased risk of developing cancers separate from the unicentric Castleman disease. But other than that, generally, it's something that you can live with, but we want to make sure that you can thrive with a UCD diagnosis. The newest subtype is oligocentric. This is the one that again emerged from the patient summit, from Penny's advocacy. So rather than just having, unicentric means it's one region of enlarged lymph nodes. So if you can cover all of your enlarged lymph nodes in your body with one hand, you have unicentric Castleman disease. The lymph nodes are in one region of the body. That's unicentric. If it takes two hands to cover them up, then that's oligocentric. They tend to be neighboring regions, so you might have enlarged lymph nodes here and here, or here and here. Maybe here. That's going to be more like oligocentric. So oligo means few. And then if you can't put your hands over all of your enlarged lymph nodes, then you have multicentric Castleman disease. And so you got multiple regions of enlarged lymph nodes. The symptoms are very different across the different subtypes of Castleman's. So even within multicentric, there's multiple subtypes. So multicentric, there's a subtype that is caused by uncontrolled infection with a virus. Human herpes virus 8 can get out of control in individuals who are HIV positive and or individuals who have a genetic mutation that makes it so they can't control viruses. So these patients, it's about even breakdown between the different multicentric Castleman's patients, but these patients typically do very well on a drug called rituximab. It actually can get the disease under control very well, and then if patients relapse, then rituximab is usually very effective. This was very, very severe, deadly, almost uniformly fatal before the utilization of rituximab. Then there's a subtype of multicentric Castleman which is caused by a cancer, Poem syndrome. Poem syndrome is a cancer like multiple myeloma. That cancer causes your Castleman disease. So in one case, a virus causes it, HHV8. In another case, cancer causes it, Poem syndrome. If you treat the Poems, then you can treat the Castlemans. And then the third category is what's called idiopathic multicentric. This is the subtype that I have, where there is no virus, there is no cancer that could explain the disease. And so idiopathic means you don't know the cause. And in this group, when you don't know the cause, it's harder to treat. And that's where we've spent so much time these last now 14 years searching for treatments since 2012. And it's because, at least with the patients where there's a virus, if you kill the cells that the virus lives in with rituximab, you control the disease. If you kill the cancer cells with Poem syndrome, you can control the disease. Idiopathic, we didn't know what to do or what to go after, and it's become clear that interleukin-6 plays a really important role. So the drug rituximab can be very effective, but in some of us, IL-6 blockade is not effective. So in order to understand Castleman's, I think it's helpful to understand what the immune system does. And so the main role for the immune system is to sort of surveil or watch over your body and look for cancers and or infections. That's the role of the immune system. So it's looking to see, is there some bacteria, some fungi, virus, are there cancers emerging? And if any of those things are present, then the immune system will attack and try to kill either the cancer cells or the virus or fungi, and then go back into a sort of a calm state. And the way that that your immune system fights things is to produce a number of proteins called cytokines. So cytokines are sort of the weapons of the immune system. They see something bad, virus, cancer, they release these cytokines to try to kill and eliminate those bad things from the body. So a healthy immune system, we sometimes use a firefighter analogy. A healthy immune system is sort of like you got a bunch of firefighters that are ready to start a fire, but they're sort of in a waiting mode. That's like your immune system. But then they see a fire and they go into attack mode. They, put out the fire. You use a lot of water to put out the fire, and in doing so, that's sort of like in the immune system, killing the cancer cells, killing the virus, killing the bacteria. And then, a good firefighter goes back to sort of a surveillance mode, as a good immune system should. In Castleman disease, it's a little different. You've got these firefighters like our immune cells, but for an unknown reason, at least in idiopathic multicentric and immunocentric Castleman disease, they start fighting fires, even though it's not clear if there is a fire to fight. So there's almost like a false alarm, and they cause a lot of damage. So there is no fire to fight, but you can imagine if firefighters were going around Philadelphia trying to put out fires that didn't exist, they would cause a lot of damage, right? And that's what we see in Castleman disease, and it never stops because there was no trigger, there was no fire, so they just keep trying to fight fires even when there isn't one, and in doing so, you have really, really significant organ damage because those cytokines, those proteins that your immune system releases to fight things, they release lots and lots of those proteins, which cause lots of damage, and it causes more harm than good. So in the CDCN, we've spent a lot of time trying to figure out what are those immune cells that are really responsible for this. There's a bunch of different cell types. There's different ways immune cells work, their pathways, the cytokines they could release, and then what you see clinically. And through the CDCN, we've been really working to dissect each aspect of this. And I think it's also important when you think about the immune system, I'll often hear people say, I take this supplement or I do this thing to strengthen my immune system. Well, in Castleman disease, many of our immune systems are almost a little too strong. So actually, you probably shouldn't be doing things to strengthen your immune system. You want a balanced immune system. So in anyone, whether it's Castleman's or not, if you have too weak of an immune system, then you will be susceptible to viruses and you will have infections that are not good. You don't want too weak of an immune system, but you also don't want too strong of an immune system, because when you have too strong of an immune system, you get autoimmune diseases, you get Castleman disease. You actually get problems from that overactive immune system. So what you really want is sort of this well-balanced immune system, and a lot of the drugs that we use in Castleman disease are attempting to get us back into balance. So you could use interleukin-6 to block one of those cytokines. You could use a drug like the one I'm on, sirolimus, to basically calm down and suppress the immune system. You can use rituximab, which kills a bunch of immune cells, but it's really all about trying to get that middle ground. You don't want to suppress it too much, but you also don't want to let it sort of run free. Symptoms, I don't need to tell you guys about symptoms. you know all the symptoms of Castleman disease. Before I go into diagnosis, any questions or thoughts on people's minds from what you heard so far? Yes, please. Yeah, so I think that, the reason I maybe joke about it is that, about symptoms, is that everyone's symptoms are sometimes a little different from other patients' symptoms. And so knowing what it is that you're dealing with, the nice thing about Castleman's is it's actually very consistent within individual patients, meaning that however you present with your Castleman disease, so if you present with, in my case, it was fatigue, nausea, abdominal pain, fluid gain, those are the things that I could really feel. Those were my symptoms, and it turned out that there was liver dysfunction and kidney dysfunction, and that was why I was gaining the fluid. But when I say it's consistent, anytime I've relapsed, it's been the exact same sets of symptoms. And we typically don't see, there's a lot of diseases where you might start with this thing and then you develop more and more and different symptoms over time. And in those cases, it's really important to know what should I be looking out for. But in the case of Castleman's, how you present is almost always how you will represent. You will keep coming back with those same presenting symptoms. And so I think it's helpful, I think, to be aware of the kinds of things to look out for. I think these are a general set of the typical symptoms, but it really, the most important thing is to pay attention to what did you feel when you were first diagnosed, what blood tests were abnormal for you, and then those are the things you should keep looking for. Because again, the good news about Castleman's is that you don't see the sort of progression of worsening or progression of new things. It's like if you present really badly one way, you will probably keep having it be bad. And if it's not as severe, then it'll just continue to be not as severe. So how do you diagnose it? Well, the first thing, we can go through this pretty quickly because you guys are already diagnosed. So you need a lymph node biopsy. the lymph node needs to look like Castleman's under the microscope. Then you need to do some sort of imaging, a CT scan or a PET scan to say, okay, I know that there's Castleman's here, but are there other enlarged lymph nodes throughout the body? Again, if you can cover it with one hand, it's unicentric. Two, it's oligocentric. And if you can't cover it up, then it's multicentric. And then once you think that someone might have multicentric Castleman's, you really need to make sure it's not something else, because there's other diseases that can look kind of like multicentric Castleman's. So lymphoma, for example, can clinically look like multicentric Castleman disease. And so you want to confirm that's not the case. Autoimmune diseases can also look like it. Infectious diseases can also look like that. So once you confirm it's not one of those other things, then you want to figure out your subtype of MCD. So I won't spend much time on this, but the lymph node biopsy, I think when I first got diagnosed with Castleman's, I was so frustrated. I was like, how come these pathologists can't diagnose it? Why are there so many questions? Why is it so difficult for them to figure this out? And the reality is it actually just is really difficult to be able to distinguish someone who has Castleman disease from something else. So it's not that the doctors are like inept or they don't know what they're doing. It really is very difficult. And it's because in many conditions, in fact, most conditions that involve blood disorders or blood cancers, there's usually a very simple test you can do with a lymph node. You can stain it for a particular protein, or you can test it for a particular mutation, and you can get a very black and white answer, like it is or it isn't the thing of interest. In Castleman disease, it's a constellation of features, and I'll go through those briefly, but like you could either have germinal centers are sort of the workhorse of the lymph node. The lymph node, by the way, the reason it's important in the immune system is the lymph node is your immune system's home base. It's where your billions of immune cells go to communicate with one another, and they go out to the body to do something. They go back to the immune system to communicate. It's like it's the home base for your immune system. And in the immune system, the germinal center is like the workhorse. It's where the most improvement and responsiveness to your environment is happening. In Castleman's, your germinal centers might be too small, or they might be too big, and so it's never the right size, but it's either too small or too big. And then there's some cells within the germinal center that can sometimes be very prominent. They're called FDC, so they look more prominent than others. But that's not a very like sort of scientific thing to say. Like that, you can just see them. They're a little bit bigger, but again, that's sort of like a bit gray. And then there can either be, usually, actually, I take that back. There's almost always lots of blood vessels, or more blood vessels than normal, but every lymph node, all the healthy individuals in this room that don't have Castleman disease, you've got a lot of blood vessels in your lymph nodes too, but we just have more blood vessels. And so what you'll hear as we go through these things is that there's nothing in a Castleman's lymph node that you can't see a shade of in another lymph node, especially in something like lymphoma. You can see all these things in lymphoma. You can see all these things in lupus. And so that's why it's really hard to diagnose this disease, because the features are all present in other conditions, but they're just more exaggerated in Castleman disease. And so, like one of these lymph nodes is a Castleman's patient, and the other lymph node is not a Castleman's patient. And I don't know if anyone wants to make a guess. Does anyone want to guess which one? Do you think the top one is the Castleman's or the bottom one's Castleman's? Any guesses? The top, you're saying top Castleman's, any other guesses? You're right, it's the top one. So the top one's Castleman's, and the reason that it is that those germinal centers are a little bit smaller. But remember, I told you, in half of Castleman's patients, the germinal centers are bigger than more normal lymph nodes. So in this top left one, they're smaller germinal centers. You can see those like circles are smaller than in a normal lymph node where they're bigger. But like I said, half of you in this room that have Castleman's, your germinal centers are bigger than the normal germinal centers. So it's not that clear. And that's why it's really important to find a great physician, because the diagnosis is not that clear and it's not that easy. And many physicians have never even heard of Castleman's or never seen Castleman's. And Madison can connect you to those physicians. Let's see. And I think one thing that maybe has been most surprising for me is that for all of you that are in the Accelerate registry, we've gone through all of your medical records, we've gone through your lymph nodes, we've looked at the slides, and then we've put them in front of the world's experts for Castleman's disease. There's a group of 7 experts. They look at every one of your cases, and if there's anything in your case that we see that is concerning, that we're worried that something is different than maybe we would expect, or maybe we think the doctor is way off, we'll actually contact that doctor and let them know, hey, we're doing this for research purposes, but we feel an obligation to contact you because there's something that we think is off. But when we go through it, the thing that surprises me the most is the discrepancies between these experts on is it Castleman's? Is it not? Is it this subtype? Is it that subtype? Again, even among the world's experts, there's a lot of debate. So you can imagine that if the world's experts, those of us who've seen hundreds and hundreds, probably at this stage, maybe thousands of Castleman's patients, then you can imagine the doctor who sees 3 in their whole career is going to have a hard time with it. So imaging, as I mentioned, CT scan is typically done. PET CT scan can be done as well. Just to distinguish the two, a CT scan will show you the anatomy, like everything that's happening in the body. A PET CT scan will show you the anatomy, so where everything is, but also show the intensity of inflammation. So you get you get a second dimension of information, not just where are the enlarged lymph nodes, but just how active are those lymph nodes. Cool. So then, similar to clinical abnormalities, symptoms, blood tests are also pretty consistent within a given patient. So like for me, when I relapse, my CRP levels go really high, my albumin goes low, my platelets go low, my hemoglobin drops, creatinine goes up. And so like I know the things that are abnormal in me. And so I know what we should be looking for, because I've had 5 of these deadly flares, and with each one, the exact same symptoms, the exact same abnormal blood tests have happened. And it's what we see repeatedly when we go through medical records from Castleman's patients. The same things happen with every recurrence of the disease. And so knowing what you had when you first got sick, knowing what was abnormal, that's going to be really important for what you should keep an eye on moving forward. And I think one thing that's I think was tough for me to swallow early on was that it's sort of like, well, isn't this what my doctor should be looking at? You know, like, do I need to really remember all this stuff? And I think I've just learned over the years that unfortunately we do need to remember this stuff. Our doctors are amazing, and we can connect you with the best in the world. But at the end of the day, you know, it's our lives, our health, our bodies, and so we've really got to be the ones who champion our health and who really, you know, keep an eye out. Even though I wish we didn't have to, I think it's really important that we do. And then I mentioned there's a bunch of other diseases that sort of look kind of like Castleman's. These are those diseases, and you recognize some of them like lymphoma and lupus. They can all look like Castleman's. And then we talked about the subtypes of multicenter Castleman disease. I'll click through these. If anyone in this room has been diagnosed with multicenter Castleman disease, but they have not been appropriately subtyped into HHV-associated, POEMS-associated, or idiopathic multicenter Castleman disease, please come up during one of the breaks, because that's really, really important. Like, we can talk through. I don't think we need to talk about it as a group, but if you've just been told I have multicentric, but you don't know your subtype, then let's definitely talk during one of the breaks, because it's really important. The treatments are very different. All 3 subtypes of MCD are treated very differently. And then a little bit of diagnostic criteria. So you need to have a lymph node that looks a certain way. You need lots of lymph nodes that are enlarged. And then you need these abnormal tests. And then you also have to exclude things that can look like Castleman's to have an IMCD diagnosis. UCD, you need the enlarged lymph node with the unusual appearance and exclude other diseases. Then oligocentric, as I mentioned, is 2 regions. Cool, so that actually, look at this, Sunita, I just put it on your slide. So this actually gets us to Sunita's session about idiopathic multicenter Castleman's. But before we start on that, what questions do you guys have? Was there anything that I shared in this sort of like background on Castleman disease that you guys have questions about or comments on? Everything in here sort of consistent with what you've experienced, or anything in here that was surprising or something that you have a question about? Yeah, please.
Okay.
Yeah.
So you said that POEMS is triggered by myeloma or something like that, but in my father's case, it started with diabetic neuropathy. So is truly POEMS or something similar?
Yeah, good question.
So it's hard to know for sure without knowing the details of your dad's case, but sometimes there can be ways to identify the type of neuropathy. So seeing a neurologist, like here at Penn, Dr. Sammy Kella, helps us a lot in terms of looking at the causes of neuropathy. The neuropathy associated with POEMS is due to deposition of
Yeah, because pretty much the only test they did, like, I don't know, neurological test and vascular endothelial growth factor, and that was all, because they found out it's really, really high.
Yeah.
And
So VEGF is very high in patients with Poem syndrome. So that's one data point. We also know it's high in people that don't have Poems, that just have idiopathic multicentric Castleman's. So a big thing will be to make sure to test the blood. It's called an SPEP, a serum protein electrophoresis, to see if there's this gemopathy that Nita was mentioning. And so that's like has to be done. And that would be helpful to understanding, like, is there potentially Poems here or is there no Poems? But so it's called SPEP, serum protein electrophoresis. That would be a really important test to do.
okay,
And your neurologist should have done
They
that.
should have.
they don't know much about Castleman.
And where in
really.
Europe? You mentioned you're in
They
Europe.
don't have to know about Castleman's. The workup of neuropathy
No.
includes an aspect. So it probably should have been done regardless of whether you think Castleman's or not.
Yeah, medicine in Romania, okay, we have some good doctors, but most of them, they're like, oh, you have something, okay, go home. It is kind of bad. But the older generation of doctors that, treat patients like this, they kind of retired, and the new generation that is like, okay, you have something, let's test it. They're coming and actually treat patients, not just goodbye.
Well, thank you for sharing that. Yeah, we'll be happy to talk to your family's doctors as well. I think that this is the IMCD session, but right now what we have in here are all the people from the prior session, which are sort of the newcomers to Castleman. So I think we probably should open up the doors and then let.
Yeah,
Right.
I'm sorry. I'm
Yeah.
running the service in the hospital.
Yeah,
so
so
I need to do my talk. So
Yeah,
you guys
cool.
can get it.
So yeah, we just need to get the right people in here, though. So okay, so what we'll do here, guys, if you have unicentric Castleman disease, there is another room, which I don't know if anyone in here, does anyone know which room it is?
It's the trivia room.
So yeah, so if you have unicentric Castleman disease, pop on out, go to the trivia room, and then if you have multicentric Castleman disease, stay in here. So you're just going to go through an IMC talk, and we'll probably get started in like 5 minutes or so. Thank you, guys.